Uh, Today I'm discussing on oxygen saturation target and an alarm limit. This is different in term newborn and preterm newborn. The hypoxia is due to ventilation and perfusion mismatch. And this hypoxia can lead to morbidity and mortality, periventricular leukomalacia, neurodevelopmental impairment, PPHN, and NEC. And hyperoxia is basically iatrogenic. Naturally, none of the babies will have hyperoxia in room air. It's always due to iatrogenic. And in term infants, there is no specific side effect. Only the in preterm there is side effect like uh, bronchopulmonary dysplasia and retinopathy of prematurity. So so we have to, if you start oxygen for hypoxic babies, we have to monitor the oxygenation to prevent above complications. The above complications are hypoxia induced like periventricular leukomalacia and neurodevelopmental impairment is very crippling to the babies, and PPHN and NEC has very bad prognosis, and bronchopulmonary dysplasia and retinopathy of prematurity also very crippling. So we have to monitor oxygenation. So oxygenation monitoring is, we can divide into like non-invasive and invasive. Non-invasive is pulse oximetry, and invasive is arterial blood gas monitoring, which we have already discussed in previous class. Pulse oximetry is defined as hemoglobin saturation of oxygen in percentage. What is the principle of oxygen measurement in pulse oximetry? It's by basically spectrometry. What we do is we keep a transducer which emits a red light, that is 660 nanometer, which is absorbed by reduced hemoglobin. And another is infrared rays, which is transducer emits infrared rays, that is 940 nanometer, which is absorbed by oxyhemoglobin. This in turn is sensed by sensor in a pulse oximeter, and this is interpreted by the software inside the pulse oximeter by using the calculation, that is oxyhemoglobin by deoxyhemoglobin plus oxyhemoglobin into 100. So normal oxygen saturation in term babies is 97%. Preterm baby is around 95% in room air. So signal extraction technology is a technology which is very good, which is not hampered by the movement of a child or a poor perfusion. The advantages of pulse oximetry: it's a non-invasive and there is no blood loss. In a preterm baby or a borderline preterm baby, blood loss is like losing a hemoglobin F. So hemoglobin F is very important for a baby to prevent all above complications. We should not lose a blood. That is why we are clamping the cord little late, almost 1 minute later after delivery. And advantage of pulse oximeter is plus or minus 3%, and it can read up to 70% of oxygen saturation. Oxygen saturation by FiO2 is surrogate for partial pressure of oxygen by FiO2. Disadvantages of pulse oximeter. There is a limitation in detecting hyperoxia. That is, see, in this sinusoid curve, partial pressure of oxygen, if it reaches, say, for example, 98% above 99%, the oxygen saturation can go above 100. It might be 120, 200. So, but in pulse oximeter reading, it will show 98. You can see HbF, it can go much above the 100%. The oxygen saturation can go very high with the partial pressure of oxygen more than 98. So this hyperoxia cannot be detected by the pulse oximeter. Choice of oximeter, we have we should choose a pulse oximeter which has a shorter average time. Most of the pulse oximeter has different age group, different the setup. We have to select the neonatal setting before putting a pulse oximeter to neonate. So which has a very shorter average time. What is average time? Average time is nothing but the time taken to read a pulse oximeter in a baby in a given time. The pulse oximeter doesn't give each and every beat oxygen saturation. It combines few the beats and then gives a reading. So that's why we should have a shorter average time in a newborn, because they have higher heart rate. So we should have a shorter average time. And that's why we have to set a pulse oximeter to neonatal setting. So motion artifact and tight fixed probe and a low perfusion can affect the pulse oximeter reading. So that's why we have to see the waveform of a pulse oximeter, and we should see the ECG monitor, how much is the heart rate. It should be equal in a pulse oximeter reading. It should be equal. So then we can see we can tell this is the correct pulse oximeter reading. Improper probe placement. For example, if thick area, if you put a pulse oximeter, the transducer may not, the whatever light emitted by the transducer doesn't reach sensor. So we should select a proper site before reading the pulse oximeter reading. Exposure to ambient light like phototherapy will impart the transducer and sensor of a pulse oximeter. So we should cover the area of the pulse oximeter reading, and also we should never tie a NIBP to the same limb of the pulse oximeter reading. Abnormal hemoglobin like methemoglobinemia in nitric oxide therapy can give higher, like in this methemoglobinemia, the oxygen saturation, the sigmoid curve will shift to the left. So oxygen may not reach the tissue in methemoglobinemia. It can give a false higher pulse oximeter reading. Severe anemia can give false low oxygen saturation, and HbF doesn't have any effect on pulse oximeter reading. Sometimes occurrence of short deep desaturation is well known. So if it occurs, we should look for any regurgitation or temperature. Is there any abnormality in a baby, and correct it. So arterial blood gas we have already discussed. It's a gold standard measurement of oxygenation. It is invasive procedure. In preterm neonates, European consensus guidelines on the management of RDS target pulse oximeter, the oxygen saturation 90 to 94%, alarm limit 89% to 95%, PaO2 of 50 millimeter of mercury to 80 millimeter of mercury. Due to presence of HbF, the 10 millimeter is lower than a normal infants. Normal infants, we tell hypoxia at around 60 millimeter of mercury. The reason is again due to this reason. The sigmoid curve in HbF, especially preterm babies, they have more hemoglobin F. So that is why they have say for example, the 80 millimeter of mercury, the oxygen saturation will be around almost 98 to 100%. At 50 millimeter of mercury of partial pressure, the oxygen saturation in preterm is almost 94%. So that is why 50 to 80 we keep. And carboxyhemoglobinemia, the shift of curve is to the left side. Correlation between PaO2, partial pressure of oxygen, and SpO2 has proportion of hemoglobin F increases with the decrease in gestational age. That means extremely preterm babies have higher hemoglobin F. Almost 90% is hemoglobin F. Shift oxygen dissociation curve to the left, HbF. Pulse oximeter reading is unreliable if in the preterm babies, because in HbF, the oxygen, partial pressure of oxygen, say for example 20, they will have oxygen saturation almost 70%. At around 40, they have almost saturation of around 85 to 90. So because of that, extremely preterm babies, periodic ABG might be required for first few days of life. So always we have to preserve HbF because it has very good affinity towards oxygen. And if you transfuse a adult hemoglobin containing blood, which has very low affinity towards oxygen, it can produce lot of oxygen toxicity in a newborn, like retinopathy of prematurity. So our oxygen target levels goals in preterm infants to meet the metabolic needs, as discussed previously, to avoid hypoxia and hyperoxia. So in resuscitation in a delivery room, previously we have discussed at different age in minutes, it's different oxygen saturation limits. So from a delivery room to NICU while transporting, and in a NICU, target for neonatal requirement requiring ongoing respiratory support, it depends on gestational age. Extreme preterm baby less than 28 weeks, oxygen saturation 90 to 95%. That same baby on reaching 32 weeks, we can increase 95 to 97% approximately. Up to 97% we can go. Very preterm and a moderate preterm, that is 28 to 34 weeks. Oxygen saturation 90% to 95%. Late preterm 34 to 37 weeks. The oxygen saturation 92 to 97%. Conditions that require individual target like bronchopulmonary dysplasia, 90 to 95%. Once reaches term, we can go above 95, up to 97. Never reach oxygen saturation up to 90, more than 98 or more than 98, 98 or more than 98. PPHN preductal, always check preductal saturation, that is 90% to 95%. In PPHN, decrease in FiO2, it should be very slow, around 2% each time. Challenges adhering to oxygen targets. In one of the Australian studies, on an average in a preterm baby, 25 times in a 24 hours, FiO2 has to be adjusted, less than 32 weeks of gestation in a 24 hours time. And it will be very difficult, but we have to do it to get a good result in a newborn. Safe SpO2 range, each NICU should have their own SpO2 range. There is a novel technology now using automated system where oxygen saturation is by the software going to the instrument like ventilator or CPAP or a high flow oxygen. There we can adjust setting, and automatically the oxygen decrease or increase will occur in the system. Alarm setting on pulse oximeter in a busy neonatal intensive care unit, an LR limit that is too narrow, leading to a large number of false alarms, must be weighed against a limit that is too wide, leading to a poor adherence to oxygen saturation targets. Like if you keep a wide range, then there can be hypoxic injury. If you keep a narrow range, there can be a false alarm and alarm overload. So each alarm, we should increase or decrease the FiO2 only by around 5%. With each alarm, if you increase too much of oxygen or decrease too much of oxygen, that is not good. The fluctuation should be around 5%. In PPHN, it should be around 2%. Educate the nursing team and the doctors, never turn off the upper limit alarm more than 97%. Repeated education sessions and monitoring for nursing and physician team is very important. Maintaining oxygen saturation within a narrow target range through multiple manual adjustment is time consuming and challenging. A qualitative study from a Canadian oxygen trial reported nurse education, prompt response to alarm, and favorable patient to staff ratio were the most important determinants of good compliance with the SpO2 alarm limits. Monitoring of oxygenation is a vital component of NICU care. Setting and maintaining appropriate target range for oxygen saturation is very important right from the labor room and right through the NICU stay. Very important to train staff appropriately to avoid hypoxia as well as hyperoxia. And every rounds we should check pulse oximeter how much alarm there is, how much alarm is there, and equally we should check a case sheet and how long they have taken to adjust the alarm limit, and then we have to give them a feedback, like the time consumed, the time taken to adjust the oxygen should be very less, so that the result will be better. Automated closed loop oxygen delivery is a useful tool which is evolving, can be considered for use. Thank you.
Thank you, Rakesh. That was a wonderful presentation, Dr. Adiga. You can stop sharing now the screen, and I request everybody as much as possible to put their videos on. Let's have a little better interaction now. So I'm going to ask anybody, maybe Dr. Samar can unmute himself. Any comments on any of the things which Dr. Rakesh presented? If you have any comments.
Good evening, sir. Actually, I joined late, but as far as I've seen the presentation. There was one thing I was wondering, which I haven't read about it before. That is, automated closed loop oxygen delivery system. What this was, I did not know.
Yeah, I'll tell you. Very nicely, of course, briefly explained by Rakesh. See, we are all having this problem all the time, and it's been estimated that on an average, about 20 to 30 times, you have to change the oxygen settings to maintain the target saturation. Now, in a very busy NICU, when you have a preterm who's on a respiratory support, you don't want the oxygen between going beyond 90 or 94. It's 90 to 94. Even if you set the alarm limits and the alarm keeps changing, the nurse may be busy doing something else. So all over the world, it's been found that there are likely to be either hypoxic states or hyperoxic states many times. So about 15 years ago, Professor Bankalari from Miami Children's Hospital, he brought out this concept of automated FiO2. Very simple. It's an auto feedback. The ventilator gives a feedback of how much FiO2 is there, and the pulse oximeter there is giving the oxygen saturation. You connect the two. So automatically the pulse oximeter comes down on lower oxygen, the FiO2 on the ventilator goes up. This is now adapted to CPAP and also to high flow nasal cannula circuit, what you call the vapotherm circuit. Vapotherm is a device for giving high flow nasal cannula, which we'll talk about later in this session on that. So it's an automated system now which has been well developed and it's been tested. It's a very good paper published by Dr. Kevin Ives from Oxford about a couple of years ago. What he found in a randomized controlled trial, when a nurse has to manually keep changing the oxygen levels versus an automated system, there is a close to 80% difference. More than 80% of the times there's a disparity in the oxygenation. That means I just read out this publication which I noted when Rakesh was managing. What he found that between the two, yes, 80%, he called the system intelligent oxygen system, where they found that hyperoxia occurred in only about 49% of the time in the intelligent oxygen system. Whereas in the manual method, 80% of the time hyperoxia occurred. And in hypoxia, it was even better. There was no case of hypoxia reported in the intelligent oxygen system, whereas in the manual method, many times hypoxia was occurring. So this therefore reduces pressure on the nurses to maintain the oxygenation. So this is a system which over a period of time is going to come. I'm sure many ventilator pulse oximeter systems are going to be connected to each other. So this is called automated oxygen. It's a simple thing which you now understood. Any other questions are there before I make some other comments, please? Gaurav, you want anything to say? No, okay. We'll have Akanksha. Akanksha, anything on the presentation by Dr. Adiga?
The presentation was very nice, and we
Great.
get the various targets. Like in PPHN, there was different target, and in preterm, there was a different target. So that was something new and very good learning to me.
So I want to ask Dr. Adiga to put up his reference for that article of the oxygen target in the group. Maybe that we all like to preserve that as an oxygen target. Maybe slides also we'll share later. But the oxygen target references, please keep it. See, I want to point out something that in today's medico-legal issues which are happening, hyperoxia is creating problems of ROP. In all of neonatology in this last about 5 years, the only cases which have been going to court and being awarded to the patient is severe ROP. In fact, recently an award of 2 crores was given to the patient party because of severe ROP causing blindness in a baby. So we are all having this unlimited oxygen circulation. We are doing in the periphery. Sometimes we don't have good pulse oximeters and we don't have good monitoring systems. So please be careful. And therefore, when such cases come up, people are looking at literature and people are coming. In fact, the recent case, which was not recent, about 5 years ago, a case from Ranchi happened where the gentleman whose child got ROP has quoted the clinical practice guidelines of National Neonatology Forum, which has mentioned the reason for ROP and very detailed it is given. He has quoted that and the case has been won by that patient. So we need to know which are the reference points. So in PPHN and all that, you need much better oxygenation. But in preterms, you have to be a little risk between 90 to 94. So please, Dr. Rakesh, just put up that reference if it is possible. Now, on this subject of, the pulse oximetry test which we do, Dr. Rakesh has briefly touched upon a thing called signal extraction technology. How many of you are using a Massimo pulse oximeter? Can anybody say if they are using?
Yes, sir, we are using.
Yes. Dr. Gaurav is
Yes,
using.
yes.
And yeah.
Yes, we
So
are.
Yes.
Now, this is something so important. Most of the pulse oximeters which are of local origin or even the good ones in the past like Nihon Corden or Nelcor or whatever it is, they have this problem that in a small preterm, especially if the child has got low perfusion, very cold limbs, or if the child is moving, you have motion artifact, the signal was not being able to be extracted well by the pulse oximeter. This does not happen with the Massimo monitor, which is called the Massimo technology or the SET technology. It's called signal extraction technology. Whatever happens, the good signals you get and the pulse oximeter is very good reading. The reason is, as Dr. Rakesh pointed out, routine pulse oximeter depends on the arterial pulsation and the deoxygenated versus the oxygenated blood in the arterial pulsation. But we also know that oxygen is carried in the venous blood and therefore, even in states where there is hypoperfused state, oxygen is there in the tissue, it's there in the interstitial bed, it is there in the capillaries, it is there in the oxygen in the venous. So this technology is able to extract the information from all this and gives a pulse, gives a reading of the oxygenation. Basically, the technology is called digital signal processing, DSP it's called. They also do what's called radio frequency, added to that. And the technology has got a computerized system called adaptive filtration. So all this put together, the technology is called SET technology or Massimo technology. So if tomorrow you have to invest in a pulse oximeter once for all, mind you, these are all very robust pulse oximeters. It's a standard of care. Use and buy a pulse oximeter which has got Massimo technology. Now what has happened, the technology has been incorporated into other pulse oximeters also. For example, Philips recently has introduced a multi-parameter monitor with a Massimo pulse oximeter. So it's like Intel inside in a computer. So this technology is now being incorporated into other pulse oximeters also. Please ask for the company people if you are ever going for a new pulse oximeter. The other thing I wanted to mention when Rakesh mentioned, try to see as much as possible when you monitor a baby on pulse oximetry preterms especially, and even in PPHN states, use the pre-ductal saturation. That's the best one to go by. Of course, in PPHN, etc., you look at the pre-ductal versus the post-ductal to see if there's any right to left shunting. That's very important. Always, even in the delivery room, most of the times nowadays pulse oximetry is needed to be used. Use the pre-ductal saturation. And the target saturation Rakesh mentioned is all pre-ductal saturation. That's very important. The other thing which I wanted to bring about is so important. Arterial blood gases from indwelling arterial lines are the gold standard. But you need not fret because it's a difficult thing to do putting an arterial line, maintaining it, also the skill used to do that. And more of us, even in intensive care units like us, just like we are doing more of non-invasive ventilation, we are using more of arterialized capillary blood gases. This is something I want you to understand. There are devices now like the iStat devices available at the bedside. We call it point of care iStat devices are available. You take a good, well warmed up heel. Now, heel, you can use the baby's heel. If the baby is warm enough, not very cold, you find that the capillary filling time is good. The baby's heels are nice and pink. Warm up the heel with a little cotton soaked in warm water. Should be lukewarm water. And keep the soaked on saline gauze for about 5 minutes on the heel. After that, when there is an arterialization of the capillary bed, that means there is vasodilatation. So with vasodilatation, what happens? The arteriolar blood and the capillary blood become very similar. Now, if you take a blood sample, which is a heel prick sample from here, and take it into a capillary tube, it is as good as taking an arteriolar blood. Now, you don't even have to use a capillary tube nowadays. Earlier days, we used to take a capillary tube and insert the capillary blood into the arterial blood gas machine, which has got a small needle or maybe a small kind of pipette-like thing into which you insert. It's not required. You have these point of care devices that are now becoming more and more cheap now. You have a device called the iStat. Anybody of you has heard about the iStat device? Yes, Gaurav says yes.
We have the iStat, but I
Yes,
actually
much,
don't
yeah.
know how to.
Yeah.
Yes, but I actually
Y-
don't know how to take blood from the capillary using it. I normally take from the artery.
No, you don't have to do that. What you do is the iStat device, you keep it next to the baby and charge. Once it's charged, and you have a simple what we call the card. The card is
The
available.
cartridge.
Either it's called a EG7 card or a CG4 card, which will give you all the parameters of the blood gas, including electrolytes, calcium, lactate. All this can be available at the bedside. We call it point of care testing. So once you have warmed up the heel well, and you can even dip the heel into a warm water kind of small cup, or just soak the heel with warm saline gauze, then dry it up, and then use a kind of lancet. Lancet is something we use for heel pricks rather than a needle prick. Any of you is using a lancet for heel pricks?
Yes, sir.
I think we should all use lancet because the blood flow is much better, and in an arterialized capillary sample, the blood just keeps flowing out very well. Now, the advantage of the cartridge which you use with the iStat is the cartridge directly into that you can instill the blood. Or if you are not very comfortable with that, you can take the blood in a small capillary tube. It just runs up into the capillary tube. Suppose you have the capillary tube kept next to the heel prick, blood just runs into it. From there, you can put it into the cartridge. You just need 10 microliters of blood. That's all. It is less than 1 drop of blood. And it can give you a full blood gas analysis. Now, remember, in an arterialized capillary, compared to the arterial blood gas, which is the gold standard, lot of data is available even in newborn and preterm literature that the pH is very reliable. If it's a well arterialized the blood has been freely flowing. The carbon dioxide is very reliable, and your bicarbonate is very reliable. Oxygen is not very reliable. It's about 15 millimeters to 20 millimeters less than an arterial. But that is okay. You know the oxygenation through the pulse oximetry anyway. So this is something, even in a level 3B unit, we do most of the times capillary blood gases. I have right now, for example, a baby on therapeutic hypothermia cooling we are doing. Of course, those kind of babies, diaphragmatic hernias, PPHNs, you need a good arterial line for a very long time. But small preterms, we just get rid of the arterial line soon and start doing only capillary blood gases because of the babies are stable, especially. And we do this all the time, and we know what is the trend of pH, bicarbonate, and CO2. That's enough. And oxygenation, anyway, we're getting it through the pulse oximeter, especially Massimo pulse oximeter is fantastic if you do that. So you see, everything is going
Sorry,
non-invasive.
can I ask quickly? Sorry, can
Yeah,
I just
Mark,
ask? So
yeah.
yes, so are you saying you fill up that cartridge, the iStat cartridge, directly from the heel? Can you do that directly from the
Yes,
heel?
you can do that. You can do that.
Oh.
Otherwise, what you can do, what we do is from the squeezed blood from the heel plate, you take it into a capillary tube, which is a pre-heparinized capillary tube. From there, you can blow it into the cartridge. That can also be done, or you can take it in a small pipette. There are very small micro pipettes available for which you can also take it into that. But it's very simple. You can just keep the cartridge close to the heel prick sample and the blood drops into it, into the chamber, into the cartridge.
And then you drop the blood into it until it goes to the filling line, and then you close.
Absolutely. That is what we have been doing.
Okay, I'll try that.
So 5 to 6 years we have been doing this and it works well for us. This is what I'm saying. And now, just for the people who are in India, in the periphery, I want you to know that the companies like iStat give the machine free. You don't have to invest. If people like Dr. Rakesh have their own hospital, you can ask the company person, even Massimo, the machine is free. You have to just buy the disposable probes. In the iStat, the cartridges are disposable. You have to only buy the cartridges. So what happens even in our hospital, we got about 30 Massimo machines, which they all came free to us many years ago. But the probes, which are disposable probes for each baby, we use it for 10, 15 days. Each of them costs about 1,200 rupees or something. That the patient is going to pay for it. So really it becomes cheap for you to, you don't have to invest anything at all. So these are some routine things which I wanted to share with you. You can start using iStat and arterialized capillary blood gas. Lancet is the only thing you have to invest into that. So small lancet you buy. It's the easy way to take the blood sample. So please do this. The other way of oxygen monitoring non-invasively is oxygen saturation index. See, arterial blood gas analysis you need to calculate the oxygenation index, which is, what is the oxygenation index? Can somebody tell me the kind of formula for that? We opened out a series on oxygen yesterday, the ventilation module. But can somebody tell me what is the oxygen index, please? Oxygenation index.
PaO2 into
Yes.
mean ventilatory pressure.
Yes.
Divided by PaO2. FiO2. Sorry. Divided by FiO2.
No. You are right in saying the mean airway pressure.
Mean airway pressure.
What we are giving on the ventilator into the FiO2
divided
into
by
100 divided by PaO2.
PaO2, yes.
Now, if you now see in this, you need a PaO2 through an arterial sample for this. But here, there's another thing which you can do, which we have done a study. I'll share those, we had the occasion to present it at the American Society for Pediatric Research. It's called the oxygen saturation index. Now, what you told me just now is the oxygenation index based on the PaO2, which is an arterial blood gas oxygen. So here, you just substitute the PaO2 by SpO2. So it is mean airway pressure on the ventilator, or let's say if it's a CPAP, you can say approximately the same, into FiO2 into 100 divided by the saturation of the baby on the monitor. So this is called oxygen saturation index. Oxygen saturation index therefore becomes easy for you to determine, because if you have a ventilated baby or you have a baby with high amounts of CPAP, you're wondering whether the child is going into respiratory failure or not. It has got a fairly linear kind of correlation with OI. So OFI and OI are almost very similar between 5 to 15. 15 and above oxygen index is very bad. That child is going into hypoxic respiratory failure, may need to be transferred to another facility for nitric oxide or subsequently ECMO. Or maybe you need to give bad prognosis to the relatives. But if you don't have a blood gas analysis arterial possible, you can just calculate OSI by the simple pulse oximeter which you have. So this is something you can all remember about it. I'll share some articles about it, and including our own study data, I'll just share it with you on the WhatsApp group later. Please remember, I'm telling you the techniques by which you can monitor children non-invasively without having to do too much of investment into bigger machines or maybe even arterial lines and all that, for which technology is required to monitor the arterial blood pressures and the oxygenation lines you have to maintain, and the skill is also required to maintain and put in these arterial lines. So just think of it. Of course, you had briefly mentioned, I made a note, you calculated the PF ratio. Dr. Adiga, you mentioned PF ratio, no? Can you unmute yourself?
Yes, yes, sir.
So
Yes,
what
sir.
is the what is the PF ratio? This is basically the PaO2 by FiO2.
Yeah.
That is a very good marker of oxygenation. So that's a very simple thing. If you have a baby with arterial blood gas analysis, you calculate the PaO2. Let's say the PaO2 is, let's say 60, divided by the FiO2. Let's say FiO2 is, let's say 40. So just tell me, anybody, what is the PF ratio in this case? Let's say Payal, how much is it? PF ratio? PaO2 divided by FiO2 into 100.
So 150.
Yeah. Normally the PF ratio should be 300 and above in a good working lung. So the lesser the PF ratio, it becomes, that means that the lung is getting bad. For the same amount of FiO2, oxygen levels are lesser and lesser. Now, if you don't have an arterial blood gas available, you can check the simple saturation which you have on the monitor. So SF ratio, we call it SF ratio. Saturation divided by FiO2. So suppose saturation is, let's say, 90%. FiO2 is 50%. What is the SF ratio then? 90 by 50.
180.
Correct. So that is what it is. So what I'm trying to say, this is another non-invasive method of determining the oxygen status of the child. So are you understanding? So our module on oxygenation has been opened up now. So many of these things, slowly you'll start understanding that you can do a lot of things non-invasively. The other monitoring device which is recently again become popular, 30 years ago it was very popular, is something called the transcutaneous PO2 monitor. Now what we are looking at is right now saturation. And Dr. Adiga mentioned that saturation and PaO2 don't parallelly go after the sigmoid curve on the upper limit. PaO2 may go high, but the saturation and this don't mismatch. You may have a very PaO2, but the saturation is still showing 99 only. PaO2 may be even crossing 150. So best way to determine the PaO2 in extreme preterms, earlier days, 30 years ago also, was something called the transcutaneous PO2 monitor. Has anybody heard about the transcutaneous PO2 monitor?
No, sir.
Yes, sir. Yes, sir.
Now, these are actually devices which have got a simple electrode which we keep it on the baby's skin, and these are called heated electrodes. They raise the temperature at the tip of the electrode to 43 degrees centigrade, and it is kept on the abdominal skin of the baby over the liver area. And then you fix a kind of tape over it, maybe a small micropore or something, you fix it. That gives you directly the temperature or the oxygen level of the baby on the monitor. It correlates 100% with the arterial PaO2. This is called the transcutaneous PO2, TCPO2. The best thing is, recently in this last 5 years, again this technology has been revived, and it is now machines like this have come into the picture. This is probably the most accurate way of non-invasively measuring oxygenation in the blood. So what happens, that heated electrode, when kept on the baby's skin, heats up the baby's skin. So there is vasodilatation which occurs severely. So therefore what happens, the skin there becomes arterialized. Like I told you about the arterialized capillary, the skin becomes arterialized. So practically the arteriolar oxygen is reflected in the electrode, and therefore you can see it on the monitor, the arteriolar oxygen. So it's almost like constant delivery of reports of oxygen in the baby's in the baby's blood. So this is called transcutaneous CO2. Well, the only disadvantage is because the skin is heated up, the electrode can be kept at one place only for 3 to 4 hours. You need to keep changing the place because otherwise the skin will burn up there. So children, babies do get a lot of erythema in the skin there. Some babies get actual burns. So that is why it is not favored much. But nevertheless, it is probably one of the most accurate ways, and it has become cheaper. The device used to be very expensive in the olden days, but now it's become cheaper also. But nevertheless, this is another non-invasive way of determining the oxygen levels in the baby. And the other way is, of course, the same way, the transcutaneous PCO2 machine has also come. It's there, it's available always, but it's become more popular now. But then that you don't need because you can do arterialized capillary to see the carbon dioxide. That is something intermittently you can do. You don't need constantly. But any of you has heard about the end-tidal carbon dioxide monitor, ETCO2?
Yes, sir. We have read.
Correct. What happens? The ventilator has a tubing and it's got flow sensors in it. We'll talk to you about ventilators when we talk about the patient-triggered ventilation. You know all that flow sensors are there. So there are many flow sensors now available which can also be incorporated in the ventilator that can give you carbon dioxide in the expired gas automatically on the monitor, on the ventilator's monitor itself. It's called ETCO2, end-tidal carbon dioxide. So you know from your remembrance about what happens in the arterial and the alveolar space. In the alveoli, carbon dioxide is about 40 millimeters of mercury. 40. So, end-tidal CO2 is a measurement of the alveolar CO2. So, if the child is not breathing well and is not breathing out his CO2, what will happen to the alveolar CO2?
Increase.
No,
It will drop.
actually be less. It will drop. Sangeeta is right. It will just drop. So that means it could be possibly due to some dysfunction in the respiratory mechanics, some CO2 has dropped in the end-tidal. So if the end-tidal CO2 is low, that means the alveolar CO2 is also low. That means the blood CO2, which is the PaCO2, that must be high. Are you understanding? So you can come to know that some respiratory kind of problem is happening and the child or maybe CO2 is getting built up in the blood. So this is a very good measurement of alveolar CO2. So this machine is also available. Now modern ventilators are incorporating end-tidal CO2s also in the machine. So these are some things which more and more as we go in the course we'll start understanding, and definitely you can incorporate many of these technologies into your day-to-day practice. The other advantage of using the iStat for Marcia, just to let you know, iStat can give you sodium, potassium. It can also give you lactate in the blood. So many times these things you don't need to take samples to send to the lab. We do it all the time. We do all this. There's different cards. The machine remains the same. These are called cards which you insert into the machine. So these are different cards available. So you can get a card for blood gas along with lactate, along with sodium, potassium. So your saving on cost becomes more if you invest only in this machine. And this machine, if you talk to the dealer, he'll give it to you free. Only the cost of the card is charged, and that anyway is charged to the patient. So I can tell you, you can do better clinical work and better quality of care can be delivered with less kind of expense if it is possible. So see if you can incorporate many of these practices into your day-to-day management in the intensive care. So now I had these points only to discuss as far as Dr. Rakesh's presentation was concerned. Your discussion on oxygen dissociation curve was very good. The only question is there was one comment you made that in HbF, I'm not sure what you mentioned, but I just want to clarify. Hemoglobin F has got a higher affinity for oxygen. All of us know that. So naturally, the newborn oxygen dissociation curve is more towards the left as compared to an adult. That's why, as you rightly said, when you give blood transfusion of adult blood, to the newborn baby, the oxygen dissociation curve can come more towards the right because the hemoglobin of the adult blood has less affinity for oxygen. So that difference is something. But this has been well exemplified in the module on oxygenation, which has been opened up from yesterday. Please go through this, and probably we'll discuss it later in the even in the PCS, which is coming up next